Yes, yes. Welcome you all to this clinical grand round, and we will be sharing our experience dealing with the COVID cases during the pandemic. So, we'll be discussing COVID-19 and GI tract. This was by Dr. Ritwik and Dr. David. Involvement of liver will be discussed by Piyush Pathak. Involvement of pancreas by Dr. Soumya Jagannathan. What we did during that phase and dealt with leaders, especially the GI endoscopy, COVID-19 pandemic, discussed by Dr. Samagra. Development of lentivirus-based SARS-CoV-2 particle by Dr. Nayak. And then, at the end, Dr. Shalimar will sum up. So over to Dr. Ritwik.
A very good evening, everyone. So I will be discussing what are the different various gastrointestinal manifestations of COVID-19. So as we know that there is intestinal tropism of the virus to the GI tract. So as we know there are expression of ACE2 receptors and TMPRSS2 receptors on the various organs of the GI tract. So we have seen in the pandemic different GI symptoms ranging from different luminal symptoms, hepatobiliary symptoms, as well as pancreatic manifestations as well, which we'll be subsequently discussing. So I'll be focusing here on what are the luminal symptoms which we have seen during the COVID-19 pandemic this time. So basically what we need to know is that there are three main mechanisms which are important. One, as I've already told you, that because there is expression of ACE2 receptors and TMPRSS2 on the enterocytes, so there is direct viral invasion by the spike glycoprotein of the virus, and predominantly we have the enterocyte damage which can lead to GI symptoms. The second being an important part is a cytokine mediated the second important point being the cytokine mediated damage. The cytokine mediated damage basically is because of the release of pro-inflammatory cytokines. So because of release of the cytokines, we also have different GI manifestations. And the third important feature is as we can see, is the gut-lung axis. So the importance of gut-lung axis basically is that there have been several studies which have shown involvement of the GI tract. There have been GI symptoms, but the viral nucleic acids were not isolated. So this has been explained predominantly by the gut-lung axis, which is an old concept, but it has gained line after the COVID-19 pandemic. That basically what we have. So there is a gut-lung axis which been operating. So whatever the GI, there is involvement of the respiratory tract by the COVID-19 virus. So there is activation of the immune system, and this activation of the immune system leads to production of the CD4 adaptive immune cells, and this can predominantly home to the GI tract and also cause subsequent symptoms. So the three important mechanisms, one being the direct invasion of the virus, the second being the cytokine mediated damage, and the third being an important gut-lung axis. So as we can see, various studies which have been done in the pandemic. So initially the studies showed the prevalence of the GI symptoms to be very high, around 70 to 80%. Then subsequently, many studies have shown that the prevalence of GI symptoms, though it being a primary respiratory pathogen, the GI symptoms have ranged. So in all different studies, it has been ranged to the amount of 15 to 25%. So after knowing what happens during COVID-19, it is important we also know the involvement, the luminal symptoms which have been seen after COVID-19. That is the long COVID or the post-acute COVID-19 syndrome, which we are normally coming across. So knowing that there is infection of the enterocytes as well, so we can expect that there is a post-infection, a group of patients are going to develop a post-infectious functional GI disorders or post-infection disorders of the gut-brain interaction. So these have been explored currently. So, taking this, we had our department had done a study which showing the long-term GI sequelae following COVID-19, which was a prospective follow-up study. So here, the basis of performing this study, as I already told you, is a direct viral invasion by the pathogen on the enterocytes. The second being also, there are prior studies which have evaluated tropical sprue, which have shown coronavirus-like particles being isolated in the various jejunal biopsies as well. And third, the very well entity, what we know about PIIBS or the post-infectious irritable bowel syndrome, which is a known entity following any acute gastroenteritis. So, assuming this, it was also assumed and postulated that COVID-19 would also subsequently lead to GI inflammation, lead to subsequent gut dysbiosis, and the most important factor being the heightened psychological stress which has been seen during the pandemic. So, all these three together would lead to altered intestinal motility, would lead to increased visceral hypersensitivity and altered intestinal permeability, which can explain the functional GI disorders what we're seeing as part of long COVID. So this study was done from April 2021 to Jan 22. It was a follow-up study of 6 months. We took basically two groups. One was the cases which had documented infection by RT-PCR or CBNAT, and the control. There were two control groups. One was Group A, which included age-matched spouses and family members of the cases who shared same dietary and environmental factors. Considering that there's a possibility of asymptomatic contact and these being the close contacts of the patients, we also took a second group B, which included COVID serology negative healthcare workers of our institute. So this was a study design. We basically followed the patients up for 6 months, and ROM4 questionnaire, which is a validated questionnaire for functional GI disorders, was administered. And patients who had functional GI disorders at 3 months were further analyzed. So what we did is we further subjected them to different lab and endoscopic tests. So this was basically done, as we know, post-infectious irritable bowel syndrome or the functional GI disorders can have underlying intestinal bacterial overgrowth, can also have underlying malabsorption, and clinically they would be presenting the same way. So knowing this population is important because we can target these with specific therapies. So that's why we further conducted some investigations. So coming to the results in the GI symptoms, we can see that among the 320 cases who we had taken, there were around 15% of them had GI symptoms during the acute infection. And predominantly the common symptom was diarrhea, which was seen around 7%, followed by abdominal pain and nausea, vomiting. Whereas coming to the results of the functional GI disorders, when we follow them at 3 months, so analyzing these patients, so as we can see at 1 month, around 11% of patients developed functional GI disorders, had some spectrum of the functional GI disorders, and later at 3 months, 8.4% persisted to have symptoms, and at 6 months, 21. That is around 6% of patients continued to have symptoms which were fulfilling the criteria of functional GI disorders. And among the various FGIDs, so we can see the IBS, that is predominantly the IBS diarrhea phenotype was the most common, and these were the other various spectrums which were documented at 3 months. So then conducting a univariate and multivariate analysis, we tried to look what are the predictive risk factors which would lead to this entity. So what we have seen are two important things. One is the severity of the COVID-19 infection. That is, patients who had moderate or severe infection were more likely to develop functional GI disorders. And the second important factor being the GI symptoms during COVID-19. So patients who had GI symptoms at baseline, so they were more likely to go on to develop functional GI disorders. So just summarizing the results, so as we can see, there were around 27 patients at 3 months of follow-up who fulfilled the criteria of functional GI disorders. They were again subjected to various different tests. And then we have showed that around in the 27 of them, there were around 9 patients who had features of malabsorption. That is, 8 of them had isolated carbohydrate malabsorption. One had malabsorption syndrome. That is, we showed there's malabsorption of 2 unrelated substances. And one patient among them also had methanogen overgrowth. That is, he was labeled as an intestinal methanogen overgrowth, and the remaining were labeled as having post-infectious functional GI disorders or disorders of gut-brain interaction. So the conclusions of this study were that patients with COVID-19, just like following any other acute viral gastroenteritis or bacterial gastroenteritis, have a higher probability of development of functional GI disorders. The second point being that moderate and severe forms of infection have a greater risk than compared to milder patients. The third conclusion being presence of GI symptoms during COVID-19 is associated with a higher frequency of development of these disorders. And by doing specific investigations, you can identify a subgroup of patients who may have underlying bacterial overgrowth or malabsorption, and these patients can be targeted by specific therapies. So as we can see, prior to the pandemic, we did not have much data on the post-infectious functional GI disorders following infections with viral pathogens. But after COVID-19, there has been significant studies which are coming up in this regard. So one important study which needs to be highlighted, this was in a study done by Dr. Ghoshal last year. So this was a multi-center study which was done both in India and Bangladesh. So roughly there were around 280 patients who were recruited in this, and they had a similar follow-up 6 months. So as you can see, the frequency of FGIDs was almost similar. It was to the tune of 6%, which was similar to what we had shown in our study as well. And similarly, now data is upcoming from the European and the American countries on this entity as well. So the second important factor, so now knowing what COVID-19 does on the GI lumen, it is important that we know what COVID-19 affects on the other luminal disorders of the GI tract. So one is celiac disease. So basically what we did, as we know, GFDs are, that's a gluten-free diet is a mainstay of treatment in celiac disease. So we had wished to see the impact of COVID-19, how it affected the adherence to a gluten-free diet. So basically a questionnaire-based study was done of 505 patients. So the questionnaire was administered to them either telephonically or if you see in personal. And around the 505 patients, we had seen almost 5% actually contacted had documented COVID-19 infection. So an important part in the results, what we had seen is pre the pandemic, around 6% of these patients had poor adherence to the gluten-free diet, which had doubled almost. It had become 13% during the time of the pandemic. And the likely factors contributing with this too was high delivery charges, increased prices of the diet, and traveling long distances. So this told that basically that in celiac patients, COVID-19 did impact the symptom control and the quality of life. Uh, I would like to invite Dr. David now to talk about the impact of COVID-19 on the inflammatory bowel disease.
Thank you, Dr. Ritvik. So my role would be to elaborate the role COVID-19 plays in patients with inflammatory bowel disease. So as you all know, inflammatory bowel disease contains two spectrums of diseases. One is ulcerative colitis and one is Crohn's disease. And most of these patients who are diagnosed with IBD are put on immunosuppressants, varying from steroids, 5-ASAs, azathioprine, or biologicals. And COVID-19, as you know, is a disease where you want your immune system to be at its peak so as to clear the virus. So there was an existing knowledge gap with regard to do IBD patients have an increased risk of developing COVID-19? What is the effect of immunosuppressants on COVID-19 in IBD? Do we need to reduce immunosuppression in COVID-19 in IBD? So we have seen patients from the other spectrum, such as CKD, hypertension, obese patients succumbing to more severe COVID effects. So we wanted to know whether IBD patients do have a similar course of illness once they contract COVID. So this was a simple study that we did titled Seroprevalence against SARS-CoV-2 in non-vaccinated patients from North India. So this sample collection was done during the before vaccination was rolled out. It was a cross-sectional study, and we included all IBD patients who are coming to our clinic more than 18 years who are willing to give consent, and we have compared that with the healthy contacts as a control group. The healthy contacts were people who are family contacts of these IBD patients, and we collected the data using a questionnaire with regard to when they had a COVID infection, what is the severity of infection, and we also collected the blood sample to measure the antibody to the spike 1 antigen, the COVID. So the data collection was done from July 2020 to April 2021, and we recruited 235 patients who were diagnosed with IBD, and we had taken 73 patients we had taken 73 controls who are healthy family contacts of IBD patients. So when we analyzed the data, we found out that when we compared these patients with IBD with healthy individuals, we found out that they almost had a similar prevalence of immunological response to COVID-19. And when we compared between the different types of IBD spectrums, UC and Crohn's disease, they also had a similar immunological response to COVID-19. So it was not much different. And we compared patients who were immunosuppressed or immunocompromised with patients who are immunocompetent. I would like to define what is immunocompromised. So we put IBD patients on steroids, we put IBD patients on immunomodulators. So in our study, we took patients who were on immunomodulators. We commonly use azathioprine, but we did not include any patient who was on biological. And immunocompetent was any patient who was who had a well-maintained disease course with 5-ASAs. And when we compared between them, we also found that it was not statistically significant. The immune response that patients had was almost similar. So we analyzed it with other studies which was done during the similar time period to know what was the rise in seroprevalence. So you can see on the right the ICMR Pan India study which was done during the early part, which showed only 1% seroprevalence. And as the time period progressed, you can see 7, 23, and 67%. So this is basically in general healthy population. And when we try to compare it with that, our IBD patients also had a similar rising seroprevalence during the course of our study period, ranging from 19 to almost 32%. So again, going ahead, we were part of another global, ICARES IBD consortium study to elaborate or stress upon the same thing. That is, whether geography and or whether immunosuppressive medications do have an impact on immunological response to COVID. So our center as well as PGI Chandigarh was a part of this multicentric study. So this was a transcontinental multi-center observational cohort study which included 7 countries: Belgium, Canada, Hong Kong, India, Japan, UK, and US. And similar to the first study, we wanted to know what is the impact of IBD therapy to SARS-CoV-2 prevalence in patients who were non-vaccinated. So this cohort included 2,303 IBD patients, and the data collection was done from May 2020 to November 2021. And we measured antibodies to the anti-spike and anti-nucleocapsid antibodies of the coronavirus. So you can see the global distribution of the seroprevalence rates. So seroprevalence was highly associated with site. You can see countries such as USA and UK where the seroprevalence is only 6, 7, and 9%. Hong Kong at virtually 0% of positivity, whereas in India you can see a very high percentage, 80 to the tune of 81.2%. So the highest recorded seroprevalence amongst all of these centers was found to be in PGI Chandigarh, where it was to the tune of 81.2, and we contributed 219 patients from both PGI and AIIMS out of the 2,303 patients who were taken for the study. So this is the chart which shows the medications which the IBD patients were on. As I've told you, we put these patients on multiple immunosuppressants, and we try to analyze what was the immunological response of these patients depending upon the various IBD therapies that they were receiving COVID-19. And we found out that patients who were only on biologicals, that is only on anti-TNFs, they had the lowest antibody positivity. That is, they had the lowest ability to mount an immunological response to COVID-19, whereas patients who were taking a combination of anti-TNFs or immunomodulators, or patients who were just on an immunomodulator alone, they had better antibody positivity rates compared to those who were just on a biological. So that's what is highlighted. Anti-S antibodies were lowest in patients on anti-TNFs alone. So these patients need to be monitored closely if they were to develop COVID-19. So we did a multivariate analysis to know what was the significant factors associated with seroprevalence to COVID-19, and we found out that a higher antibody association was found to be related to the geographical region in which the patients were, male sex, and immunomodulators. So these are the factors which contribute to an increased antibody response to COVID-19, whereas patients who were just on a biological therapy was associated. So this is the other data which was done during the similar time period from UK, Italy, and other European countries. So you can see that it is just 0.5 to 21% the total positivity response to COVID-19, whereas in India, both of the studies that we were part of, we can see a much higher seroprevalence to the tune of 32 and 81.2%. So why this high seroprevalence is there? It basically depends upon the surrogate of infection risk. The first thing which I would like to tell is seroprevalence in IBD patients are not different from healthy contacts. So you don't need to treat IBD patients differently from any other healthy patient. You can treat them like any other healthy individual. No need to discontinue the medication. Basically, what contributes to antibody response is their previous history of COVID-19, or whether they have had a previous hospitalization to COVID-19, which explains why India has had such a high seroprevalence rates when compared to other countries. And regarding immunosuppressives, they do have an independent effect on seroconversion irrespective of the geographical region. And patients who are taking anti-TNFs, for example, infliximab and such anti-TNFs, they need to be monitored closely because they do have a lower seroconversion rate, so they have a lower propensity to mount an immune response to COVID-19. That ends my talk. I would like to invite Dr. Piyush to elaborate the effects of COVID on liver.
Thank you, Dr. David. So I will be touching upon the another aspect of this COVID-19 pandemic that affected our liver patients, which constitutes a unique group of patients because of their impaired nutrition status, because of their comorbidities, and because of unique character of the involvement of liver. So as we can see here that liver can be involved in various ways. As asymptomatic transaminases rise, patient can have jaundice, the clinical manifestation. He can have a new decompensation, may develop acute or chronic liver failure, can have a newer entity termed as COVID-associated cholangiopathy, or he can have just a biliary manifestation in the form of acalculous cholecystitis and other. So, what is the basis of liver injury that we see in our liver patients due to COVID-19? Various mechanisms have been proposed, including a direct cytopathy because of expression of ACE2 and TMPS PRSS2 receptors on cholangiocytes, or liver can be just a bystander because of immune mediated damage, because of some drugs which are primarily used to treat COVID like anti-IL-6, remdesivir, or liver can bear a second hit because of systemic effects of hypoxemia, hypotension, or there can be separate hepatotoxic factors like alcohol, viral hepatitis, or NASH. So transaminases are increased in up to 50% of cases of COVID infection. AST is usually elevated than more than ALT, and we also see a rise in gamma GGT. So the involvement of liver is mainly multifactorial. The presentation of a cirrhotic patient who develops a COVID-19 ranges from pneumonia to cytokine storm leading to other organ failure to liver specific manifestation. He can have just a mere rise of transaminases. He can have acute decompensation of his cirrhosis. He can present with ACLF and very rarely acute liver failure. So, when we analyzed our patients during the first wave of COVID from April to June 2020, about 750 patients who presented to AIIMS emergency, 28 of them having liver disease and 26 were cirrhotic. And when we analyze this, then they can present with a various manifestation including decompensation, acute decompensation, ACLF, a combination of respiratory symptoms with decompensation. So summarizing this, we can say that about 46% this presented with complications of cirrhosis, either decompensation, varicose bleed, ascites worsening, or about 11% presented with respiratory symptoms alone and 42% presented with a combination of these symptoms. So this is the same data which analyzed, and it showed that the mortality was especially higher in the patient who presented with ACLF, and about all 9 of them died. And the cause of death in these patients was ARDS and MODS, multiple organ dysfunction, and the severe COVID was the cause of all this, and it was present in about 77% of those with ACLF, and mild to moderate was 1 in each. This was the same data that also included the patients from first wave and from the second wave from April to June 2021, and it included about 221 patients with COVID-19 and cirrhosis. And here we showed that about 18 had compensated, 139 had decompensated, and 64 were having ACLF. So what we found here that the overall mortality was 40% in our cirrhotic cohort, and the highest mortality was seen in ACLF patients, means those who had organ failures, about 72%. In the same database, we also showed that the patients were similar in both the waves of COVID. The only difference was that in second wave of COVID, the more patient presented with severe COVID infection, as the second wave was mostly caused by Delta variant. Similarly, the both groups were similar with respect to their age and other factors, and patients with ACLF again had more severe COVID infection than those with compensated cirrhosis and those having simple decompensation. So in the same study, we studied the predictors of outcome, and we can see that the markers of severity of liver disease impacted the outcome of patient. Here, those who had ACLF, that means those who had organ failure, had especially poor survival, and here those who had more severe cirrhosis had especially poor survival. So when we analyze this, the independent predictors of mortality in this cohort of patients were a high leukocyte count, their alkaline phosphatase, raised creatinine, severity of COVID disease, and the severity of underlying liver disease. So this was the largest database from NHS UK, which studied the impact of various comorbidities and the death related to COVID. So here they showed various risk factors including obesity associated with increased COVID-related deaths, diabetes, recent malignancy, hematological. Here they showed that presence of chronic liver disease was also associated with increased mortality due to COVID. So now coming on to the management, what we learned, how do we manage these patients in emergency? The management depends on the basic treatable etiology. If it is present, likely antivirals for viral hep, standard management of complications of cirrhosis, standard management for variceal bleed, for ascites, hepatic encephalopathy, the management for sepsis, and some therapies which have not established in the trials. The management of COVID-19 and organ failure remain the same as we use in other critical care setting for these patients without liver dysfunction. So after we treated the patient and when we discharge these patients, we showed here that the survival after discharge in those cirrhotics with COVID-19 was same as those patient of cirrhotic who did not develop COVID. The first graph was showing the two cohorts which were unmatched. The second graph was showing the matched controls, and they showed that the survival did not differ up to 360 days when we followed our cohort. 92 patients were included in both these cohorts. So coming on to some specific points, we know that various drugs were used to treat COVID-related, COVID pneumonia, COVID-related ARDS, severe COVID, including remdesivir, anti-IL-6, and anti-JAK inhibitors. One of them was remdesivir, which was recommended. And here these two trials have showed that the liver injury because of this drug was not different in the two groups as against placebo and those who have received remdesivir. Similarly, here also there was no difference. So the guidelines recommend you should stop this drug if patient develop ALT more than 10 times or he is symptomatic. You can restart if ALT becomes less than 5 times elevated. Similarly, other drugs, anti-JAK, anti-IL-6, they can also have liver toxicity, and their use in severe liver dysfunction is also should be used with caution or not recommended. We all know that COVID-19 is associated with coagulation abnormalities. Here we used a 27 patients cohort and studied their coagulation parameter using thromboelastography. About all these 27 patients, we saw that the normal tag was seen in 30% patients. The tag was hypercoagulable in about 63% and it was hypocoagulable in 2 patients. And those 2 patients in whom the tag was hypocoagulable had especially poor survival. Both of these 2 patients had DIC and both of them died. Survival also depend on these coagulation parameters which we showed here. So the management of a cirrhotic patient is a lifelong process. We have to screen them, we have to keep them on surveillance for HCC, and the COVID restrictions which were imposed, they had an impact on the cancer management here. This was a global study from these countries and it showed that as the restrictions of lockdown increased, the care affected of all these cancer patients. Another study from India, from Indian cohort, it showed that during the lockdown after the first COVID wave, there was a percent reduction of 50% or more in new OPD registration, chemotherapy, and major surgeries in all these cancer patients. We also analyzed our data of 36 patients with hepatocellular carcinoma, and here we see that after this first wave of COVID, there was about a 7 months median lag in their care. So you can see that their baseline AFP levels has progressed during this period and their stage migration also occurred. Means now after 7 months, a progressive disease was seen in 70% of patients who were of lower BCLC class initially. It also impacted the further management and only 2 of them were amenable for further ablative therapies in the form of RFA and rest all other received the palliative therapy in the form of chemo PACE. So this was one more registry that showed the global impact of first wave of COVID-19 on liver transplant recipients in both the worlds. Here we showed, we can see that after this COVID-19 pandemic, the number of patients and number of centers where more patients were listed for COVID were reduced in after lockdown. There were higher wait list mortality. Center performing more liver transplant was less in the post COVID lockdown period. So COVID also impacted the care of our cirrhotic patients, also affected the management of liver transplant, and it delayed the process and resulted in higher mortality in all these patients. The discussion of COVID is not complete without the discussion of COVID vaccine. So here we showed that the data of our cirrhotic patient, because prior studies have showed that the cirrhotic patient may mount a less immune response because due to COVID vaccine, which is also showed in the cohort of patient who had a liver transplant. So here we conducted one study from May to December 21, and we showed that about 99% cirrhotic developed anti-spike antibody, and only 4 developed a COVID infection after receiving 2 doses of Covishield. So this was our data, and we can see here that in both compensated and decompensated cirrhosis, whether the patient has child A, B, C cirrhosis, the difference in anti-spike and neutralizing antibody was not there. It's all these two groups produced the same level of antibodies. So coming on the duration between the 2 doses of Covishield, we also showed in our study that the duration of less than 6 weeks was less effective as compared to any duration more than 6 weeks. Whether you administer up to 12 weeks or more than 12 weeks, the antibody titer was comparable in all these, which were less in those who received 2 doses less than 6 weeks apart. So a prior study showed a less immunogenicity in liver transplant recipient. In this study, they also showed that the antibody production in those without cirrhosis and those with cirrhosis was almost comparable, but in those with liver transplantation, they produced less amount of antibodies in that. And they concluded that a poor immune response to COVID vaccine was seen in those who had a liver transplant, those who are on 2 or more immunosuppression, and those who received vaccination with a single dose of this vaccine. So guidelines recommend vaccination of all liver transplant recipient and all cirrhotic patients because the benefit outweighs risk. Touching upon the one more aspect of entity that is associated with likely a direct cytopathy of COVID-19 virus in the liver. Here, this study they showed that the cohort of patients with liver disease, about 15% of them developed a secondary sclerosing cholangitis, and it was especially associated with metabolic risk factor. Up to 60% of this cohort was having metabolic risk factor in the form of NAFLD or NASH as compared to other etiologies of cirrhosis. So what they showed here that it can present as a typical sclerosing cholangitis with a typical bleeding because of stricture and proximal dilatation, a typical pruning of due to peripheral loss of bile ducts with a CSD stricture. Here you can see that increased signal intensity because of localized inflammation, and here you can see dilated bile ducts, all cholangiectasis because of this secondary sclerosing cholangitis, which they describe. So a lot of complementary medicines have been used during this pandemic. One of them was Giloy, and various studies have showed its effect on the liver, and it has been implicated as a cause of liver injury in these patients. This was one recent study that included 43 of patients having liver injury attributed to Giloy, and the presentation was acute hepatitis in about 44%, acute worsening of their liver disease in about half of them, and ALF-like presentation is about 5% of them. The liver biopsy showed a hepatocellular pattern of injury in more than half of them, and about 3/4 of them had cholestasis on liver biopsy. So the outcome of them was favorable, and about 86% of them recovered had stable LFTs at baseline. So the key learning points here is that the first 2 waves of COVID-19 were associated with severe clinical presentation, increased rate of hospital admissions, and increased mortality. Vaccination leads to good antibody titers in cirrhotics and also those with liver transplantation. So it is recommended in both these cohorts. Prevention of COVID-19 is important, especially in cirrhotics, and unnecessary use of drugs should be avoided in this cohort of patients. So now I would like to invite Dr. Somya to discuss about the COVID-19 and its pancreatic manifestation.
So during the initial part of the pandemic, January 2020 till February, when the virus was predominantly localized to the China and was spreading to other continent, in few cases of severe and non-severe COVID, patients have more elevated amylase and lipid level, more so in patients with severe disease, and imaging shows evidence of enlarged pancreas, but none of them had necrotizing pancreatitis. So this raised a possibility whether the virus can affect pancreas or whether it is due to some other drug-related pancreatitis, as the patients are on multiple drugs, multiple therapy. So during that period, we published our initial case series of 5 patients. So three patients had initial phase of respiratory failure and severe pancreatitis, and subsequently they were admitted, and due to prolonged hospitalization during first wave, they detected to have SARS-CoV. They got infection of SARS-CoV-2, and since they had initial respiratory failure due to pancreatitis, there was a possibly potential of having respiratory failure due to COVID, because they were prone to having respiratory failure. But out of the 3 patients, only one had moderate pneumonia. So we thought that there could be a possibility of difference in post response for lung injury to the virus and pancreatitis, which may be due to underlying compensatory anti-inflammatory response phase of the disease. And in that case series, we reported 2 patients who presented with pain only and no fever, and they had COVID positive. They were and detected to have RT-PCR positive for the COVID, and they did not have any cause for pancreatitis. So this raised a possibility whether the virus can cause pancreatitis. So there were few animal experimental studies where the SARS-CoV-2 virus entry factors such as ACE2 and TMPRSS2 were localized to the SNR cells, and the virus is seen being multiplied in the SNR cells as well as the beta cells of the pancreas. So there are post-mortem studies which are showing that these patients are having necrotizing pancreatitis. During the initial phase of the pandemic, there was few case series of patients presenting with pancreatitis and detected to have COVID positive. Of this largest series is of 149 patients of whole of 18 centers from the UK over 2 months, and surprisingly, a substantial proportion of patients have cause of the pancreatitis is not known. And when you compared this group of patients with pancreatitis and COVID positive with pancreatitis only, they had higher mortality and higher ICU stay. So we tried to conduct a prospective multi-center study from August 2020 till February 2021 to evaluate whether this virus may be implicated in the cause of pancreatitis, to evaluate the organ failure and in-hospital mortality, as all of the prior study were retrospective in nature, and this evaluation was lacking in these studies. So pancreatitis, severe acute pancreatitis, the pathophysiology is severe systemic inflammation resulting in cytokine storm. Similar pathophysiology is also there in patients with severe COVID. So suppose a patient develops pancreatitis and detect to have COVID positive, and day 3 patient had respiratory failure. The PF ratio is 112 in both the patients, and if you do a chest X-ray, this is the finding, and in another patient this is the finding. So if the patient can have respiratory failure due to pancreatitis, and the most common organ failure in severe acute pancreatitis is respiratory failure, and obviously the virus can affect the lung and that can cause respiratory failure. So differentiating the respiratory failure due to pancreatitis and due to COVID was of paramount importance in that phase, because you have some therapy available to target the respiratory failure due to the virus, such as steroids and in some cases tocilizumab and antivirals also. But in pancreatitis, most of the therapy is mostly supportive. So in this patient, when you did a CT, you can find that patient with pancreatitis related respiratory failure, predominantly basal collapse consolidation and changes in the lung interstitium, and in patient with COVID related respiratory failure, they have characteristic features of the COVID pneumonia, and both these patients had necrotizing pancreatitis. So in patient 2, we could provide steroids or tocilizumab for respiratory failure part. So in this study, we included 85 patients. So we divided into 3 groups. So if the patient developed pancreatitis and within 2 weeks they had RT-PCR positive for COVID, and you don't find any other etiology for pancreatitis, we classified them as COVID-related pancreatitis, which was a term which was coined by our department. And we had 18 patients of COVID-related pancreatitis, of which 8 patients died, and 4 died due to critical COVID, and 2 due to both severe pancreatitis and COVID. And some patients who were detected to have COVID positive within 14 days of onset of pancreatitis, but they had other etiology of pancreatitis. We call them COVID co-infection and acute pancreatitis. And those patients who are hospitalized already for pancreatitis, and since they are patient with severe acute pancreatitis who are hospitalized for 2 to 3 months, and during the pandemic they have chances of acquiring the virus, so we call them COVID superimpression in acute pancreatitis. In this group also, critical COVID was there in 8 patients. All this data was mostly recorded in alpha and delta wave. So there was severe COVID during that period, and subsequent mortality. So when we compared the whole cohort with propensity matched cohort during the period when COVID was not there, that was a historical control of 230 patients matching the severity of pancreatitis. We could see that the patient have higher organ failure and higher in-hospital mortality, and 9 patients in COVID-related pancreatitis had necrotizing pancreatitis also. So to conclude in the study, patient with COVID-related pancreatitis had post outcome with higher mortality of 44% and adjusted odds ratio of 2.8 as compared to other etiology and matched non-COVID acute pancreatitis. And it is the severity of both the disease, the pancreatitis and COVID, which resulted in higher and additional mortality in this subpopulation of patient. So the lesson we learned from this COVID pandemic is that we could develop a model of we could learn the virus related pancreatitis in great detail, and there was a common conception that virus related pancreatitis usually is mild as it is systemic illness and pancreas is just affected, but that was not the case. Virus can cause also necrotizing pancreatitis, and it can increase mortality due to its affection to the lung. And this excess mortality in this dual disease model is governed by both severity of pancreatitis and severity of COVID. I would like to invite Dr. Samagra to talk about the endoscopy part.
Good evening, everyone. So, as we very well know, like all the aspects were affected significantly, endoscopy was also affected significantly amidst the COVID pandemic. And when we look at the point of view of different stakeholders, the priorities and concerns were very different. So when we look at from the point of view of patients, when we look at it from the point of view of fellows, endoscopy unit personnel and administrators, we find a different set of concerns. However, a common concern during that time was concern for safety. And why was this an important concern? Endoscopy is now known to be a aerosol as well as droplet generating procedure, as a number of elegant studies have shown that endoscopy increases the production of both aerosol and droplets more than twofold. And because of this, our key priorities during the pandemic was to minimize the transmission risk as far as possible, and to limit the risk that is occurring, and to assess the amount of risk that a person might incur while undergoing endoscopy. So during the first wave, we were trying to develop novel devices. This was developed by one of our residents. It is a low-cost device, and it essentially involves 2 masks and a mouth guard, and along with that, a plastic shield is provided. And the idea is that by applying this onto the patient in this manner, we can actually limit the amount of aerosols and droplets to which an endoscopist and staff are exposed while undergoing endoscopy. Obviously, this did not catch on, but this was one of our initial efforts. As the pandemic moved on, we realized that a large amount of risk is incurred during emergency endoscopies. And we tried to limit our emergency endoscopies by stressing upon conservative management. And we were able to show in a series of 23 patients who presented with upper GI bleed that all of these patients could be managed conservatively very well. And none of these patients had rebleed at 5 days and mortality at 5 days. Obviously, this was a small data set, but this was one of the experiences that stressed that conservative management is very important in these subset of patients. Further, we also did a survey of endoscopic practices at different centers. This was one of our surveys that we did, and we included hospitals like GB Pant, PGI Chandigarh, CMC Vellore, and SGPGI Lucknow. And we were able to show that all of these hospitals had significant decrease in the number of endoscopies performed per day, and most of them were down to 10 to 15% of their usual numbers. In addition to that, most of them were only performing endoscopies for urgent indications, and most of the semi-urgent or elective indications were delayed. And what we found in addition to that was that most of these patients, most of these centers which were performing endoscopy in that manner with the complete PPE, they were able to restrict the spread of COVID-19. So at that time, the local positivity rate on community was around 4.5 to 5%, and the number of endoscopy unit personnel who became positive was also similar, around 4%. And we estimated that the rate of healthcare worker infection is quite low at 0.26% per 100 endoscopies. So we concluded that if we use proper PPE, the risk of COVID-19 spread is in fact low during endoscopies, and we were able to conclude that mandatory pre-procedural testing may not be needed for all patients. In fact, in Italy as well, similar study was conducted, and they were also able to show that the risk of transmission to healthcare workers is low, and endoscopy can be carried on for all indications as usual. So this brings us to the conclusions, and what we showed was that the risk of COVID-19 transmission during endoscopy is quite low, and we might not require COVID-19 testing for all patients who are presenting for endoscopy. Although during the pandemic, we continued with the hospital policy of pre-procedural testing for all patients, and this risk may be further reduced by effective conservative management of patients, and by this we can limit emergency endoscopy and delay it to a more routine setting. I will now like to call Dr. Nayak to continue the discussion.
So, as you know, the SARS coronavirus 2 in with binding of the spike protein, the S2 receptor, and subsequent cleavage by host protease like TMPRSS2. So, then this infection, if you see the extrapulmonary infection, like the virus replication in GI tract or liver, mostly due to presence of S2 receptors and S2 receptor and different proteases. So the distribution usually varies from the different, starting from the GI tract to and other organs. So basically, and at the same time, we are also seeing there are several mutations are coming in the spike protein during the emergence of the variants. So we need a infection model to see at the same time we can incorporate the mutations which are happening during the pandemic in spike protein, and you can see whether how the tropism is affected. So we had basically developed a model, infection model. Basically, you can call it a pseudovirus, SARS-CoV-2 virus pseudovirus. So pseudo means is a false virus. So here what we are using, so we had used a lentivirus system, so that you can produce a pseudovirus. So basically here you have we are using a 3 genome strategy. like 3 plasmid co-transcription strategy, where you will have a lentivirus genome which will express a reporter gene like EGF, and you will have a packaging plasmid who will give the capsid protein, and you will have different envelope proteins. So for this, we are using SARS coronavirus 2 spike protein as an envelope, and we have two. One is wild type. We have a modified with HA tagged, hemagglutinin tagged spike protein, and we have a VSB-G protein. So basically, when you have these 3 plasmid, when you will transfect a cell, you can produce a virus. So now, once you had to find the virus, we had tried to see the tropism. So basically, first we confirm the expression of the spike protein. So as you know, when the spike protein you will express in the cell, it should produce like full length spike protein. But we had used here a anti-HA. Here we had used a anti-HA antibody. Using that, we can see both the splicing H2 protein and a full length protein. So that means in the cell, like this is a HEK 293 cells like kidney cell line, it is having some proteases which can cleave this protein. So then the pseudovirus particle, we try to see whether it could able to infect uh, in the cell lines. So for the infection, you need a H2 receptor. So we did in two ways. We had put H2 receptor overexpression, and simultaneously we also overexpress H2 and TMPRSS2. In the both case, we could able to get viral infections. You can see the fluorescence. So as you know, there are several proteases present besides like TMPRSS2, other proteases like cathepsin, you have trypsin, you have furin like protease. So some of these proteases also cleave the spike protein, and which can help in attachment of the virus to the cell membrane. So now we have developed the model. So as you know here, the spike protein, you have the wild type spike protein, which is like around the novel 2019 virus strain. And as the strains are evolving, starting from alpha variant, this is beta variant, this is gamma variant, and this is delta variant. You can see there are a lot of mutations are accumulated in this spike protein, particularly in the receptor binding domain here. If you are having like N501Y, you will have like increased transmissibility. Similarly, so if you see delta variant, you are having a different mutations, whereas alpha, beta, gamma, you will find some mutations which is giving the increasing transmissibility, and it is helps in escape mutation of the virus. So now our goal is to develop the same way we'll incorporated these mutation in our spike protein by side-directed mutagenesis, and we'll develop the pseudoparticle of emerging variants. So right now, whatever we have done with wild-type virus, then we'll develop the pseudoparticle of the wild-type emerging variants, and we'll do infection and GI tropism study, GI tropism and enteric and hepatoma cell line, so that this will serve as a model for study to the infection. Uh, Basically, this is a model for viral infection. So similarly, we had also developed adenovirus based viruses which can express both SARS coronavirus 2 non-structural and structural protein. The data we have not shown here. So this can be used to this we can use for to study host immune response. So these are a virus, but this is the indirect way. This is a viral vector based, which is developed by the reverse genetic approach. So both way we have two models now ready. One is to study in viral infection, other is to study host immune response. So the host immune response we had also summarized in a review article we had published. So that's all. I would like to thank for the grant agency like ICMR and AIIMS intramural for this. I would like to call Dr. Sal.
So apart from what you've heard so far, the department also contributed in the literature. We did a couple of meta-analysis, and these were published, and these added to the knowledge about how to manage COVID-19. Telemedicine was an important thing what we learned how to manage patients, and predominantly all patients when the hospital was shut because of the lockdown, we did and were almost calling up almost 100 to 200 patients per day and taking care of them, answering all their queries, giving them prescriptions which were sent to them on WhatsApp or other modalities. And important, we also created an awareness about vaccination and answered the questions and did a lot of counseling, which our residents were constantly involved in the COVID-19 period. So, what did we learn during this period? So, gastrointestinal manifestations are common with COVID-19. Risk of COVID-19 infection with GI diseases similar to the general population. We observed a poor outcome in patients with cirrhosis and those with pancreatitis patients with COVID-19. The first two waves really had a big impact in terms of hospitalization, and we didn't have beds for admitting patients, and we did observe a very high mortality in these select group of patients. Vaccination is effective, and evolving data is there that all patients need to be vaccinated, and telemedicine helped us manage these patients really well. So in the end, I'd like to acknowledge various departments, all departments of AIIMS, all the administrative staff, the faculty, all students who are actively involved in the participation, residents across all departments helped in the management of these patients, nursing staff, research staff, and other staff were all actively involved. All laboratories worked almost 24 hours to ensure that we had the reports in managing these patients. We had a good amount of funding, and the initial all laboratory tests were based on funding and special reagents which were procured by ICMR. And nonetheless, to say is about the AIIMS research section, which did a lot of intramural funding, which helped us in organizing, and the studies which we have presented were funded predominantly by the intramural grants from the research section, and also other agencies who's contributed to the funding that helped us doing all this work which we have presented over here. So with this, I'd like to end out here the presentation and would like to invite comments from my teachers, Professor Ahuja, Professor Govind Makharia, and any comments from the and any questions which are there from the audience.
How do you think medicine would change now from the lessons we have learned from COVID? I'm not talking of COVID as a subject,
I think
but
we
overall,
learned.
the practice of medicine, what do you think are the key take homes from?
I think the most important key take home message which we our experience suggested learning points, teamwork. Something is what we really learned is how across departments residents came in and we could train people who are not involved in patient management to come across and manage and help. Second came is the use of technology. I think technology really helped us in managing patients. Now, I'll give you an example. Like we had groups on WhatsApp and where we could have live information on what's happening to these patients. We were not using these technologies at that time in clinical practice, but it was available. And we at that time learned from there how we can easily access the information and change management. And at that time where patients had COVID-19 and you could not have so much of access, like not all doctors could go and see a particular patient, but across specialities, people contribute.
So, like,
Yeah.
for example, would you say that radiology rounds have changed now and
Yeah.
they may continue to remain the same way? Then your collaborative meetings across different institutes, do you think that it would change?
Yeah.
Then telemedicine, then education, the way you're educating people.
I think that's a very important. Like I was not involved in and sort of academic sort of contribute or say studies involving different institutes. Now I'm involved so much of different and technology has changed. Zoom has come in. There are multiple other platforms, so that has really helped. And I think we need to continue that practice. That really helps. You can have a multidisciplinary team meetings on these technologies on one platform, maybe anywhere, but you can contribute to and be part of the management of that patient. I think that's a very important lesson as we learned during this pandemic, and this is probably going to stay. Sir, please.
I think a small point to make that once humans are pushed to the wall, they respond. And the COVID pandemic is one example, starting from diagnostics to therapeutics to vaccines within just 1.5 years. Also scaling up to the level that you do billions of people vaccinated within just 1 year. That's a fantastic thing to learn from this pandemic, that humans have a huge capacity to respond to any emergency.
Do we have questions from the house or any comments? So if there are no comments and no further comments and questions, so I'd like to thank everyone, you who've taken out your time to come over here. And I'd like to especially thank all the faculty, all the residents. Things would not have worked, and what we are here, we did a lot of good work, but that was all a teamwork. So that's what important thing is, how you can work as a team and help in improving the outcomes of patients.